Hello, everybody. Reed here. Today, um, we're going to have a discussion on primary pain disorders. You know, I had a patient um, who came in one day, complaining that they had a lot of pain. They had a physical injury, needed surgery, and so there was more than enough reasons to justify that they were having pain. You didn't think the person was being dishonest. However, in this situation, you know, in behavioral health or mental health, we don't actually treat the actual pain disorder itself, but the pain has two components. There's a physical component from the physical body, and then there's a psychological component, right? And we need to make sure we aggressively treat the psychological component so that the pain becomes bearable and the pain become manageable. So we don't want the pain to um, get out of control. So I have Grok here. Okay, and let me just search what it says. And I think I need to increase the size of the font on here. Let me see, how would I increase the size of the Zoom? Okay, and then whoa, whoa, whoa. Okay, so let's see, window, Zoom, what? Window, Zoom. Okay. All right, but let's make the text. I'll check next time. So here, let me look here on Grok. This is a free, I have a free account on it. I found that this is very interesting, asking the search engines to sort of explain it. And I'm sure it searches all the public and online resources about the issue and sort of aggregates it and simplify it. But here, let's see, we're here, explain. Explain the diagnosis and treatment of a primary pain disorder. Let me get my DSM-5 real quick. Always have it handy. It seems to be thinking a lot about this. Okay, primary. Okay. Yeah, it doesn't have this as a primary pain disorder here. Okay. It doesn't seem to be coming up with here. A primary pain. No, this is not what I'm looking for. What's the DSM-4 criteria for a primary pain disorder? Okay. Okay. So here, what is a chronic primary pain? So they're fudging with the names, but previously it was called primary pain disorder. Chronic primary pain is a category of chronic pain recognized by the International Classification of Diseases, okay, ICD-11, okay, and defined by this. It refers to pain that persists or reoccur for longer than 3 months in one or more anatomic regions and is associated with a significant emotional amount of emotional distress, such as anxiety and depression, or functional disability, such as interference with daily activity or social roles, and cannot be better explained by another underlying condition or a symptom of different chronic pain syndrome. Okay, unlike secondary pain, which stems from the identifiable disease or injury, primary pain is considered a disease in its own right, involving central nervous system sensitization, where pain signals are amplified without ongoing tissue damage. This online resource is very interesting because it's pulling features that I didn't read in the textbook. So it seems to be blending multiple sources. And I think this is one of the things, the difference between that primary pain and secondary pain. So let me just review this real quick. Okay, it refers to pain that persists or reoccur longer than 3 months in one or more anatomical regions and is associated with significant emotional stress, depression, anxiety. And now here, this is the piece that we target here with the emotional, psychological distress. What is best to do in this situation is sort of look at the patient with the primary pain disorder and sort of look at it as the source of a lot of suffering and agitation. And this predisposing factor here continues to radiate and start to affect almost everything. So in terms of the psychological functioning, it worsens or enhances psychotic symptoms, hallucinations, delusional disorganization, right? It can intensify, magnify, worsen symptoms of bipolar, such as mixed manic episodes associated with combativeness, agitation, aggressiveness, or manic episodes like euphoria, erotomania, hyperactivity, and things, psychomotor agitation, restlessness, things like that in the mania. So, and then also it can still precipitate major depressive episodes or even worsen anxiety and things like that. So that primary pain disorder is very important to ask patients about pain and to make sure that you have a plan to sort of manage the emotional and psychological stress that comes along with being in constant pain. And it's horrible. It's horrible for many of these patients to be in this situation. And so it's very important that you look at their psychological and emotional state. And here, if we aggressively treat these symptoms, then it seems as if their emotional and psychological performance increased significantly, and now their perception of the pain may be significantly decreased, or their ability or capacity, their feeling that they can manage the pain that's not as overwhelming or overburdening for them. Again, it creates the functional disabilities. Interference with daily activities or social roles. This is a significant issue. If they get impairment in their ability to, let's say, move around, then they're at risk of becoming isolated and or alienated. If they're isolated or alienated, they simply won't be in the same reality of the people who's around them. And so it leads to other sort of interpersonal difficulties, functional, and it cannot be explained by another underlying disorder or as a symptoms of a different chronic pain syndrome. Like if you have rods in your back, that's different, All right. Okay. Unlike secondary pain, okay, which stems from an identifiable disease, okay, process such as arthritis or nerve damage. Primary pain is considered a disease in its own right, right? It often involves central nervous system sensitization, where pain signals are amplified without ongoing tissue damage. That's the mechanism. The common examples include, fibromyalgia, okay, chronic primary musculoskeletal pain, irritable bowel syndrome, where the pain is the irritable bowel. The pain is the most dominant symptom in the bowel, and non-specific low back pain. Okay. Diagnosis. Diagnosing chronic primary pain is primarily clinical and involves a process of exclusion combined with positive criteria. And there is no single definitive test or imaging or blood work that can confirm it. You get the hunch. What's interesting? What's interesting? The patients are in a lot of pain. They bear the pain and still have a conversation with you, and they can be in a lot of pain and even take a whole history and don't even tell you they're in pain unless you ask. And they can be in excruciating pain, but having psychologically to hold this in and deal with all other the issues they're managing in their life is a bit too much. And so it's important to really to sort of look out for this. And one of the things you're going to notice is just the pain is just unbearable for them. And then you'll start to see, look for the symptoms of depression or anxiety or cognitive changes or things like that. But it's not going to be a checklist or anything like that, like a test that you can do to find it. Okay. In the DSM-5, the diagnosis most closely aligned with a primary pain disorder is a somatic symptom disorder with predominant pain. Okay. The DSM-5 does not use primary pain disorder explicitly, as this concept is more prominent in ICD-11, with classification chronic primary pain as a distinctive entity. Yeah, I knew I picked it up. I thought it was in the DSM-5, not the ICD-11. However, somatic symptom disorder with predominant pain captures similar cases where pain is the primary complaint, but is not fully explained by medical condition. Okay, let me see here. I don't want to go too much into this here. Oh, okay. Let's just go through the criteria. But this is somatic symptom disorder. Again, they said, I guess I'm using the wrong outdated terminology. You can see the last time I picked up it changed. Somatic symptom disorder. So I guess I should go back and say, instead of primary pain disorder, I should go back and relabel it somatic symptom disorder. All right. One or more somatic problems that are distressing or results in significant disruption in daily life. Right. One or more somatic symptoms, distressing and significant disruption. Okay. In the case of primary pain disorder, the somatic symptoms is persistent pain that causes significant distress or functional impairment. So that persistent pain, significant distress, functional impairment. Hold on a second. Significant disorder. Okay, let's see here. All right. Excessive thoughts, feelings, or behaviors related to the somatic symptoms or associated health concerns. Right. And this is the piece here, this excessive thoughts, this excessive feelings, excessive behaviors. So remember psychoticism, things like that. Remember the mood related symptoms and things like that. And remember the cognitive functioning that leads to behavioral disruption is still right there in the system clusters there. Disproportionate and persistent thoughts about seriousness of the symptoms. You see this here? These sort of ruminations are very difficult because they just go on and on and on. It creates just a lot of internal tension in the patients. Look, persistently high levels of anxiety about health symptoms. Look, excessive time and energy devoted to these symptoms and concerns. Yeah. So you can see why we will really want to treat this. Let's see here. Okay. No, explain the mechanism of pathology, dysfunction. And I'm going to try to find the mechanism of I know they said increased CNS sensitization to pain. So what is that? Lower the pain. Oh, CNS central sensitization, altered pain modulation. Okay, peripheral contributions. Okay, social and economic factors. Yeah, plasticity and chronicity. This is amazing. Okay, let me just see if I can go through this and stick to the stuff that I know. All right, primary pain is category of chronic pain recognized. Okay, all right, we got through that. Diagnosis chronic pain is primary. Oh, we did this part. Okay, we did that part. Okay, all right, we did this part. Okay. The mechanism of dysfunction in a primary pain disorder um, um, involves complex interactions between the central nervous system, peripheral nervous system, and psychosocial factors. Um, I was trying to get to the strategy of treating primary pain disorders. Basically, the strategy, and I'm not sure if I picked that up here on this search engine here, but the strategy is to, let me show you the dorsal root ganglion. This dorsal root ganglion, okay, I sip out cookies. Okay, so this dorsal root ganglion is where the afferent fibers go in, I believe, connect to the mesothalamic pathway, to the not the mesothalamic, to the spinal thalamic pathway. I believe his afferent goes through the dorsal root and then goes up to the spinal thalamic. If I'm wrong, I still if I'm wrong, let me please correct me. But the strategy, this ganglion here, the dorsal root ganglion, is filled with norepinephrine and a lot of serotonergic receptors. And so one of the things we do as a strategy is we try to block the afferent activity going into the spinal thalamic tract. And we try to block it by, the increasing dose of blocking the norepinephrine and serotonin reuptake pumps to increase the amount of norepinephrine and serotonin. And this sort of disrupts the communication in the ganglion, and then there's fewer afferent signals going up. And so so we use tricyclic antidepressants, particularly like Elavil or Remeron or things like that. And try to push them up to reasonable doses to make sure that we're trying to increase as much norepinephrine and serotonin in that dorsal root ganglion as possible to decrease the afferent signal. Now, this also does something else. It's a more aggressive plan to treat the depressive and the anxiety elements there by basically giving them a tricyclic antidepressant that helps with depression and anxiety. But I wasn't sure if this search engine was going to describe that mechanism, or if my knowledge is outdated. Well, we'll see. Okay. Unlike secondary pain disorders where pain is directly attributable to an identifiable disease or injury, such as arthritis or nerve damage, primary disorders are characterized by pain that persists beyond their expected healing times, often without clear tissue damage, and is considered a disease in its own right. Remember, so primary pain disorders are characterized by pain that persists beyond expected healing time. So when they present, the symptom is primarily of the pain and of the discomfort, right? Often without clear tissue damage, right? And it's considered a disease in its own right. That's why we have to I always list it separately and definitely try to treat it. The key mechanism underlying these disorders is central sensitization, accompanied by altered pain processing and modulation, influenced by biological, psychological, and social factors. Below is a detailed explanation of the mechanism of dysfunction. Hey, central sensitization, then altered pain modulation, then a peripheral contribution, psychosocial and emotional factors. Primary pain disorders are strongly influenced by the biopsychosocial model, right? If your relationship isn't going well, if you're not having enough finances, if your living circumstances, if those things are all disrupted, then the emotional, psychological impact is significant. And so I think it creates to the emotional component, exacerbates everything, where psychological and social factors interact with biological mechanisms to exacerbate the pain. Emotional distress, anxiety, depression, or stress can amplify pain perception by activating brain regions like the amygdala. That's the mechanism. Wow. Which heightens the emotional response. That reminds me always trying to keep people down, keep people calm down, and you don't want the amygdala to pop out. It makes sense. Emotional distress amplify pain perception by activating the brain regions like amygdala, which heightens emotional responses to pain. Cognitive factors, catastrophizing. Remember, I told you about the dangers of using the primitive defense mechanisms? All animals use defense mechanisms. The difference between us and animals is they don't have any higher other defense mechanisms. If they did, they would probably take over, right? Cognitive factors, catastrophizing or hypervigilance to body sensations can reinforce pain pathways and increase disability. Yep. Social factors, lack of support, isolation, work-related stress, narcs at work, cultural attitudes towards pain, knocked out in the community. Knocks out in the community. Okay, let me see here. Chronic primary pain involves maladaptive neuroplasticity, where the nervous system learns to perpetuate pain, rewiring pain circuits and memory of pain. Prolonged pain leads to structural changes in the CNS, such as increase in dendritic branching and altered connectivity in pain processing. The brain may develop pain memory, which persists even after the initial trigger resolves due to entrenched neural pathways. Jeez. So let me see here with central centralization. Central sensitization is the hallmark of primary pain disorder. Okay, central sensitization. It refers to an amplified response to the CNS to sensory input, resulting in heightened pain perception even in the absence of ongoing tissue damage. Wow, heightened pain perception even in the absence of ongoing tissue damage. Hyperexcitability of neurons. Neurons in the spinal cord and brain, meaning the dorsal horn neurons, become overly responsive to stimuli and amplifying pain signals. This is driven by changes in synaptic plasticity, where repeated stimulation strengthens pain's pathways. Lowered pain thresholds. Normal sensory inputs, such as touch or pressure, may be perceived as painful, or mild pain stimuli may be perceived as severe. Neurotransmitter dysregulation. Increased levels of excitatory neurotransmitters such as glutamate and substance P. I knew glutamate was going to. Anytime there is something going a problem, glutamate is there. Glutamate and substance P for that pain issue. And reduce activities of inhibitory hormone. Yeah, that balance here, decrease GABA, decrease serotonin. Yeah. All right. Brain changes. Structural and functional changes in the brain region are involved in pain processing. such as the anterior cingulate cortex, insula, prefrontal cortex, amplify pain perception and emotional responses to pain. That's one of the, also with chronic pain, also use Depakote frequently with it. I go with Depakote because you want to decrease raise the seizure threshold and decrease a lot of that synaptic activity that slows down these, like the prefrontal cortex and things like that. Okay, let's see. Then altered pain. So this is the central sensitization. Okay, hyperexcitability of neurons, lower page threshold, neurotransmitter deregulation, and brain changes. An altered pain modulator. The body's ability to modulate pain through descending pathways from the brain to the spinal cord is impaired in primary pain disorder. The body's ability to modulate pain through descending pathways, impaired descending inhibition, and enhanced descending facilitation. Normally, the brain releases endogenous opiates, serotonin, and norepinephrine to dampen pain signals. In primary pain disorders, these inhibitory pathways are less effective, leading to unchecked pain amplification. Wow. So the higher corticals start modify pain even further. Enhanced descending facilitation. In some cases, descending pathways may paradoxically increase pain signals, further perpetuating the pain experience. Sounds good. Okay, and I think so. Here we're at the 26-minute mark here. Let me see. Let me have a question here. Let's see. Hi, Dr. Reed. Hey, buddy, how's it going? I read that the descending spinal serotonin pathway directly inhibits the activity of the dorsal horn neuron, mainly via 5-HT receptors. They suppress body inputs that reach the brain. I think this is exactly what you're describing here, right here. Let me know if this is what you're describing, Okay. Hey, iHash, how's it going, buddy? Appreciate your comments. Can neuroplasticity explain why pain persists long after the injury heals? Bingo. Neuroplasticity, yeah. Chronic primary pains involve maladaptation of the neuroplasticity, where the nervous system learns to perpetuate pain. This one also, what was the other one? Yeah. Oh, okay. Preventing the brain from interpreting pain. If inhibition is deficient, there may not be enough serotonin to mask nociceptive, irrelevant inputs, so the people have pain from the things that are. You should have just came on the show. You should have just came on the show. It's not usually a pain issue. Contributing to painful somatic pain symptoms and depression, fibromyalgia, anxiety, and irritable bowel syndrome. That connection to mental health disorders is so eye-opening in a deeper level. It is, buddy. Thank you for the input, but I appreciate it. Here, Umber, how's it going, buddy? The primary pain disorder more of a central sensitization process or a maladaptive neuroplasticity issue? Both of them. This is very interesting because it seems as if the Grok explains it in everyday language, and so you sort of it seems to be better than a textbook. I don't want to say that. Okay, I think we're here at 28 minutes. I only want to keep it around 20 minutes, and so I think that's it for today. I hope this was very helpful for you guys, and I'll keep doing these as we go along, and make sure you go back through my site and look at all the other videos on the neurotransmitters, the pathways, and take a look at those and give me some input if you like. But until then, Reed, I'll talk to you guys later. Take care, guys. Ciao.